Most people over 60 are told the same thing when they notice blood in the urine. Wait and see if it happens again. It sounds sensible. It sounds safe. But here is what nobody tells you. Waiting alone does not protect your independence, because the one warning sign that matters most is the one that disappears on its own. Urology clinics see this every single day. Someone notices pink or rust-colored urine one morning, it has cleared by the evening, and they decide it must have been nothing. Months later, sitting in a specialist office, the sentence they say most often is that they wish they had made one phone call. Over the next 20 minutes, I am going to walk you through 5 things nobody tells you about blood in the urine after 60. Plus the one insight most appointments never have time to cover. The number 1 item on this list is something almost nobody talks about. Stay with me until the end, because that one can change how you approach the next 10 years. Here is the problem with the way this gets handled. The average appointment runs about 12 minutes. In those 12 minutes, your doctor has to hear your story, review your medicines, check your pressure, and deal with whatever brought you in that day. Blood that has already stopped sounds like a problem that solved itself. So it gets written down as probably an infection, probably the blood thinner, probably nothing. And the visit moves on, because there is no room for the second conversation. I am not here to sell you a supplement or scare you into a course. This channel exists to give you the science a 12-minute appointment never has time to cover. Nothing in this video asks you to buy anything. Everything in it is designed to make your next appointment sharper, because the stake here is not simply a diagnosis. The stake is whether something gets found while it is small and simple, or after it has taken your energy, your calendar, and your ability to run your own life. Independence is easiest to keep when nothing has been allowed to grow quietly in the background. Tell me in the comments how old you are and what state or country you are watching from. I read those, and they tell me exactly who I am talking to. Now here is the one mechanism behind everything that follows. Please do not skip this section. It is the key to everything that comes after it. Your urinary tract is a sealed system. 2 kidneys filter the blood. 2 narrow tubes carry the urine down. The bladder holds it, and 1 final tube carries it out. From the filter to the exit, that whole path is lined with a waterproof wall, and it is meant to be watertight. Think of it like the water main running under your street. Clean water goes in at one end and comes out at your kitchen tap, and you never see anything in it that was not supposed to be there. If rust-colored water comes out one morning, nobody says the water is broken. They say something along the pipe is damaged, and they go looking for exactly where. Blood in your urine is that same message. It is not a disease by itself. It is a leak, and the only useful question is where along the line it came from. That is why wait and see is the wrong instinct. The right instinct is find the spot. If this is already making sense to you, tap the like button so more seniors can find it. Number 5 is the infection assumption. It is the most common explanation offered, and it is often correct, and that is exactly what makes it dangerous. Urinary infections become far more common as we age, and they do irritate the bladder lining until it bleeds a little. Picture the inside of your bladder as a smooth painted wall. An infection is like damp seeping into that wall, softening the surface until it weeps. Antibiotics dry the damp out, and the weeping stops. But drying the damp tells you nothing about whether there was already a crack underneath. Major urology guidelines are clear on this point. Blood in the urine that appeared alongside an infection must be shown to be gone after the infection is treated, not assumed to be gone. So here is the protocol. Finish every single dose of the antibiotic you were given, even after you feel completely well by day 2. Then ask your office to schedule a repeat urine test about 6 weeks after the last dose. Ask for that appointment before you leave, because nobody will call to remind you. If red blood cells are still there on that repeat test, that is the moment to ask for imaging of the kidneys and a look inside the bladder. And notice something now, in advance. A true bladder infection almost always brings burning, urgency, or a change in smell. Here is your guardrail. Never stop an antibiotic early because the color cleared, and never take leftover pills from a previous round. And here is your stop condition. Fever of 100.4 or higher, shaking chills, or pain in your back at the level of your lower ribs means you call the same day, not next week. That combination can move quickly in someone over 60. Pair this with one simple habit. Keep a small notebook by the bathroom and write the date of every single episode, along with the color. Memory blurs dates within 2 weeks, and the date pattern is often what makes the doctor pay attention. Now, infection at least gives you something to treat. Item 4 is different. It is the explanation that feels so obvious that people stop looking entirely, and it is the one that hides the most. Number 4 is the blood thinner and the beet trap. These are two separate traps that fool people in exactly the same way. Start with the food. Beets, blackberries, rhubarb, and strong food dye can all tint urine pink or red without a single red blood cell in it. Certain medicines do it too, including some bladder pain tablets, some laxatives containing senna, and one antibiotic used for tuberculosis. That is the harmless version, and it clears fast. Now the serious one. Many people over 60 take a blood thinner, and when the urine turns red, the assumption is that the medicine caused it. Large urology series have consistently shown that people on blood thinners who develop visible blood in the urine have serious findings at rates similar to everyone else. The thinner did not drill the hole. It found the crack that was already there and made it visible sooner. So here is the protocol. Run a 48-hour test. Remove beets, blackberries, rhubarb, and any dyed food or drink for 2 full days. If the color is still there after those 48 hours, food is not your answer. Next, ask for a urinalysis with microscopy, not just the dipstick strip. Say those words at the desk. The strip can react to things that are not blood, while microscopy actually counts the cells. And 3 or more red blood cells in a single field is the recognized threshold. Your guardrail here is the most important sentence in this section. Do not stop or reduce a blood thinner on your own for any reason. Those medicines are preventing a stroke, and stopping one without guidance is trading a question for a catastrophe. If you take a blood thinner, talk to your doctor before changing anything at all. Pair this with a photograph of every medicine bottle you own, taken on your phone this week. It turns a 5-minute conversation into a 30-second one. Now hold that thought about things that look like an explanation but are not one, because item 1 is the purest example of it on this entire list. First, the one that comes with a pain you will never forget. Number 3 is the kidney stone, and specifically the one that announces itself and the one that does not. Urine is water carrying dissolved minerals. When it gets too concentrated, those minerals fall out of solution and form crystals, the way sugar settles at the bottom of a glass of tea that was stirred too little. A stone with a rough surface dragging along that smooth internal lining scrapes it, and it bleeds. Some stones cause pain that doubles a grown adult over. Others sit silently and only show up as blood on a test. Large population studies have consistently shown that stone disease is more common with age and rises sharply with dehydration, which is one reason it is so common in older adults who deliberately drink less to avoid nighttime trips. Here is the protocol, and it needs one safety step first. Ask your doctor what your personal daily fluid target is before you change anything. Because if you take a water pill or you have heart failure or kidney disease, more fluid is not automatically better for you. For most other adults, the goal is enough fluid to keep urine the color of pale straw, rather than apple juice. That usually means roughly 8 to 10 cups spread across the day. Take the largest amount in the morning and taper after about 6 in the evening, so you are protecting sleep as well as kidneys. And keep sodium under about 2,300 milligrams a day. because salt pushes calcium into the urine where stones are built. Your guardrail. Do not treat stone pain at home with rest and fluids alone. Here is the stop condition, and it is a hard one. Stone pain together with a fever of 100.4 or higher, shaking chills, or vomiting is an emergency the same day. An infection trapped behind a stone can turn serious within hours. Pair the fluid habit with a measured container. Fill a 2-liter jug in the morning and drink from only that, because guessing at cups over a whole day is how people end up half a liter short without knowing it. And here is what a stone cannot do for you. Finding one does not close the case. Plenty of people over 60 have a stone and something else at the same time, which brings us to the assumption that ends more investigations than any other. Number 2 is the assumption that it is just the prostate, or just the change of life. For men, an enlarged prostate really can bleed. As it grows, the surface develops fragile new vessels, like an old plaster wall covered in hairline cracks, and those vessels break easily. That is real, but it is a conclusion you reach after the other possibilities have been ruled out, never a conclusion you start with. For women after menopause, tissues thin and blood can come from the vaginal area rather than the bladder at all. And that is a separate conversation with your own doctor that also deserves a phone call rather than a wait. Urology guidelines are consistent here. Visible blood in the urine is evaluated on its own merits, even when a known prostate condition is already sitting in the chart. Here is the protocol, and it costs you nothing but attention. Notice which third of the stream is red. Blood mainly at the beginning points toward the outlet tube. Blood mainly at the end points toward the bladder neck or the prostate. Blood spread evenly through the whole stream points higher up, toward the bladder or the kidney. Write down which of those 3 you saw, along with whether there were any clots. Then ask the office for a clean catch specimen. That means wiping first and collecting from the middle of the stream, not the first drops. And if you are a woman who is not certain of the source, say that out loud at the desk. They can then collect the sample in a way that removes the doubt entirely. Your guardrail. Do not stop a prostate medicine on your own, and do not settle for a home dipstick kit as your final answer. Stop condition. If you cannot pass urine at all, or clots are blocking the stream, that is an emergency room visit tonight, not a morning phone call. Pair this with the notebook from earlier and bring the actual pages to the appointment. Read them out loud rather than handing the pages over. Handing someone 3 dated lines is far more powerful than saying it happened a while back. Now everything so far has had a visible cause you could point at. Item number 1 has no pain, no burning, and no obvious explanation. And that is precisely why it is number 1. Number 1 is visible blood that comes once, causes no pain at all, and disappears completely on its own. This is the presentation that gets ignored more than any other, and the reason is human rather than medical. We are built to treat pain as the alarm. No pain feels like no problem. But the lining of the bladder has very few pain nerves in its surface layer. Something can be growing on that surface for a long time without ever producing a single ache. Think of a slow leak inside a wall of your house. There is no noise, no smell, and no discomfort. You only see it on the day a stain appears on the ceiling. And then it dries and the stain fades. The leak did not stop because the stain faded. It just stopped showing. That is exactly how bleeding from the bladder surface behaves. It comes, it stops, and the stopping feels like healing when it is only the tide going out. Here is the clinical reality, stated plainly and without drama. Visible blood in the urine in adults over 60 is the single most important urinary warning sign there is, and the risk of finding something serious is meaningfully higher in this age group than in younger adults. Bladder cancer is diagnosed most often in people in their 70s, and a history of smoking, even smoking you quit 30 years ago, is the strongest known risk factor for it. So here is the fullest protocol on this list. Call within a few days of the episode, not at your next routine visit. Use one exact sentence when you call. I had visible blood in my urine, and I would like it evaluated. Do not soften it into, it looked a bit dark. Ask for 3 specific things by name: a urinalysis with microscopy, imaging of the kidneys and the tubes above the bladder, which is usually a specialized scan called a CT urogram, and a look inside the bladder with a small camera, called a cystoscopy. The standard for visible blood is to look, not to guess. If you have ever smoked, say so in that first phone call, because it changes how urgently your case is treated. Write down 4 details before you call: the date, the color, whether there were clots, and whether there was any pain. And if the color never comes back before your appointment, keep the appointment anyway. Your guardrail matters just as much. This is not a diagnosis, and it is not a reason to panic tonight. Most causes of blood in the urine turn out to be entirely benign, and the whole purpose of the workup is to find that boring answer and let you stop wondering. Do not attempt to test or treat this at home with cranberry products, extra water, or anything else while you wait. Here is your stop condition: heavy bleeding, clots you cannot pass, inability to urinate, or feeling faint and lightheaded means the emergency room tonight. Pair the phone call with one more decision. If you still smoke, this is the week, because the bladder concentrates and stores what the lungs absorb. And pair it with your written log, so the story arrives complete. Now here is the payoff I promised you at the beginning. Everything on this list has an explanation attached to it: infection, medication, food, a stone, a prostate. Item number 1 is the only one that arrives with no explanation at all, and that absence is the information. Painless is not harmless. Disappearing is not resolving. One episode is enough. Consider a typical case documented in the urology literature. A 71-year-old man, a former smoker who had quit at 50, noticed his urine was pink one morning. There was no burning, no pain, and no fever. By that afternoon, it was completely clear, and he decided it had been the blackberries. 9 months later, it returned, and this time he called. The evaluation followed the standard path: a urine test with microscopy, a scan of the kidneys and the tubes above the bladder, and a camera examination of the bladder itself. The finding was a growth confined to the surface layer of the bladder wall. Because it had not moved into the muscle beneath, it was removed through the bladder in a single procedure, without removing the bladder. He was back to his own routine within weeks, drove himself to his own follow-up visits, and moved on to a schedule of regular checks. Nothing about his day-to-day independence changed. What separates that outcome from a much harder one is not luck and not genetics. It is the distance between the first episode and the first phone call. In his case, that gap was 9 months, and the second episode is what finally closed it. It did not have to be that way. So here is your action list: 5 steps, each one with a number in it, and it is short on purpose. Tonight, write 4 things on a single piece of paper: the date you saw blood, the color, whether there were clots, and whether there was any pain. 4 details. 1 page, 5 minutes. Tomorrow, make 1 phone call and use the exact sentence from item number 1. I had visible blood in my urine, and I would like it evaluated. Ask for an appointment within the next 7 days, and if the first offer is 6 weeks out, say that sentence again. This week, ask for 3 things by name: a urinalysis with microscopy, imaging of the upper urinary tract, and a look inside the bladder with a camera. Write those 3 down before you go, because nobody remembers all 3 in the room. This week also, photograph every medicine bottle in your cabinet with your phone. Include the blood thinner, the prostate tablet, and anything you bought without a prescription. It turns a 5-minute conversation into a 30-second one. And starting today, If you were treated for a urinary infection at any point in the last 2 months, book the repeat urine test for 6 weeks after your last antibiotic dose. Book it now while you are thinking about it, because that one appointment is the one nobody ever calls to remind you about. Think of someone in your life who has mentioned this once and then never brought it up again. A parent, a spouse, a neighbor. Send them this video because the whole point of it is one phone call that would otherwise never get made. Tell me in the comments which of these you are starting tonight. Your answers decide exactly what I cover next. And if you want the science that a 12-minute appointment never has time to cover, subscribe to this channel, because that is the only thing this channel exists to do. This video is education, not a diagnosis. Your own doctor knows your history, so bring this list to your next appointment. I'm Warren Hayes. Don't forget to subscribe and live longer.